Turning to focal therapy, what are our limitations and what are our abilities? Well, one of our limitations is we would really like to have better imaging. And I see the two imaging technologies that are moving in that direction to actually be combined into one. One is the MRI, and the other is ultrasound, which we currently use regularly. You can make some decisions about how aggressive you want to treat. If you have a prostate that has no evidence of disease on, let's say, the left side, but you have a fairly sizable lesion on the right side, would you just try to treat that lesion, or would you just treat the whole side? That would be called hemiablation. So in general, whole gland therapy is for higher risk patients. Focal therapy is for low risk patients. And as a percentage, it's roughly 25% of the patients who are diagnosed as having prostate cancer who fit into this low risk category. PSA is a byproduct of prostate cell metabolism. And in benign tissue, there is a certain identifiable chemical profile to PSA. In the presence of cancer, the PSA has a different chemical profile, and this is known as pro-PSA. PCA3, we use this in our practice. RNA, it's a certain type of ribonucleic acid. It is overproduced in malignant prostate. You can find some of this RNA in patients who we believe have prostate cancer. This too is being tested. It sounds good, it looks good, but it's not ready for prime time. PSA is still the gold standard. It's still what we use as our major biomarker. Let's talk about the erectile function and dysfunction that's related, for instance, to curative treatment of prostate cancer. What about the organ, the tissues that actually go through the process in trapping blood and then releasing it, the difference between erection and flaccidity? Well, first off, you have to do whatever you're doing right. And so we would call this nerve sparing. Vascular injury, neural injury, muscle injury, all can impact on how the system works. This is a very sophisticated mechanism. This is a cross-section. These are the erectile bodies. These are the blood vessels, the nerves. The 5 PDE inhibitors, which are Levitra, Viagra, and Cialis. One of their major contributors may be that it preserves the lining of the blood vessels. Statins, drugs that currently are being used for people who have high cholesterol, things of that nature, thought to lower the cholesterol. One of their major functions may be to preserve the lining cells of the blood vessels. This is also a preservative that will keep the erectile mechanism intact if the appropriate signals to it have been disrupted. So the point is that whether you're using one of the 5-phosphodiesterase inhibitors, one of the statins that keep the erectile tissue healthy, the bottom line is it's an important thing to do. Angiogenesis in a complex way means that if you have a tumor, a cancer, for instance, it will generate new blood vessels. It will draw blood vessels into where that tumor has arisen. Technique where you can inject microbubbles. They'll find this fluid growth of vessels. And when you do ultrasound, the bubbles will rupture from the ultrasound energy and give you a much brighter image where you have neovascularity. It's a targeting system, so we can begin to identify where these new growths, these tumors are, particularly the index lesions. Another way we can look at it is with power Doppler. Power Doppler is an ultrasound system that will show flow in blood vessels, synthesizing the image from ultrasound and MRI, which is technically possible, will give us the ability to sharpen the focus of the ultrasound to be able to guide the biopsy to the areas or be able to guide the cryoprobes to the treatment site or the index cancer that we're trying to eradicate. Active surveillance, careful selection of low-risk patients to follow carefully, monitoring, treatment of people who have progression of disease. Active surveillance is a part of not over-treating, not having your prostate taken out if it doesn't need to be taken out, not having global cryotherapy if you don't need to have cryotherapy, not having radiation therapy if you don't need it. So that's part of what active surveillance does. It takes the edge off the overdiagnosis. But is there a better way? We think there is. How do we select patients for focal therapy? We look for the low grade of tumor. We look for the size of the cancer within the biopsy specimen. We look at the volume of the cancer as we measure it with mapping biopsies, so it's selective biopsying of certain groups of patients. But the whole idea is, in focal ablation, is to take care of the bad cells and preserve the organ. Not just preserve it, but preserve its function. What we're really looking at is for patients, for the most part, who have disease confined to one side of the prostate and the other side is clean by mapping biopsy. And we have patients in our practice who we have done this level of focal therapy on for about the last 3.5 years. So this isn't new to us. The higher our levels of doubt, the more aggressive the therapy. Is the index lesion really the driver? We think it really is, and there's a lot of literature, and I'll refer you again to the website. You can read this yourself, that the genetic identity of the metastatic lesions is consistent with the index lesion and not with what we say are the low-level activity or indolent lesions within the prostate. All this data is maturing and giving us a new option, which for the moment we're looking at is hemiablation, but I think we'll soon be able to say we're able to do true focal ablation. The ideal patient for treatment would be a low-grade lesion, slowly rising PSA, a patient who's probably in their mid-60s and who's highly motivated.